Okay. Okay, look at the pharmacotherapy for smoking cessation. Varenicline more effective than either bupropion or NRT, like nicotine replacement therapy, long-acting NRT, a nicotine patch, and short-acting NRT, nasal spray, gum, lozenge, inhaler, decrease craving and daytime withdrawal symptom, decrease craving and daytime withdrawal symptoms. Long-acting NRT may be combined with short-acting NRT, like patch plus gum, to improve efficacy. And bupropion, there is decreased post-cessation weight gain, good choice for patients with unipolar depression. Okay, contraindicated in patients with seizure and eating disorder. This is very important. Bupropion is contraindicated in patients with seizures and eating disorder. Okay, now most smokers attempt to quit several times using different pharmacologic and behavioral approach before they are finally successful. All these patients who are ready to quit should be offered behavioral counseling, which has been proved to increase rates of sustained smoking cessation. In addition, most patients benefit from pharmacotherapy, which further increase the success rate. Options include following: nicotine replacement therapy (NRT), bupropion, varenicline. Nicotine replacement therapy to decrease the withdrawal symptoms and nicotine cravings, a combination of long-acting NRT patch with a short-acting NRT gum and lozenge nasal spray. A termed a patch plus regimen is more effective than either modality alone. NRT can be used alone or concurrently with either bupropion or varenicline. NRT alone is an appropriate choice for this patient who did not tolerate varenicline. Bupropion is a norepinephrine and dopamine reuptake inhibitor and antidepressant. Increases the success rate, may help to reduce weight gain after smoking cessation. It is contraindicated in patients with active eating disorders or a history of seizures. However, it is less effective than either varenicline or combination NRT. Varenicline is a high affinity nicotine receptor partial agonist that increases long-term success rate for smoking cessation and is most effective pharmacotherapy available. It has a high smoking cessation rate than NRT and bupropion, despite initial concern about increasing the risk for suicide and depression. Newer findings have shown no increased neuropsychiatric risk. Next. Okay, patients receiving chronic opioid therapy are at risk of opioid overdose, including those with cancer. In general, patients with prostate cancer or isolated bony metastasis can live for many years. Therefore, balancing adequate pain control versus avoiding opioid overdose is crucial because overdose leads to fatal respiratory overdose leads to fatal respiratory depression. Naloxone, an opioid receptor antagonist, should be offered to every patient receiving chronic opioid therapy, especially those at high risk for overdose. Family member should a family member should be trained on its use. Naloxone reverses the effects of opioid therapy and can be administered intranasally, intramuscularly by standards pending arrival of emergency medical services. Patients at high risk overdose include those with following characteristics: escalating or high dose opioid therapy, such as this patient, concurrent benzodiazepine, history of substance use disorder or overdose, and close contact children who may accidentally ingest the drug. Okay, the last four line, like patients are at high risk for overdose. So these are the patients who are high risk for overdose, like high dose opioid therapies, concurrent benzos. Okay, got it. Okay, it's autism spectrum disorder. When patients, when parents of young children express concern about a child's communication skill, social development, and or inability to tolerate minor change, tantrums, excessive crying, it is important to rule out autism spectrum disorder. Language, this patient's delayed language development, of joint atten- in an absence of joint attention, spontaneous attempt to share interest or spontaneous attempt to share interest with others by eye gazing and pointing at the object. Repetitive behaviors, hand flapping, are concerned for ASD. At age 18 months, children should have vocabulary of approximately 10 to 25 words. 10 to 25 words. Make eye contact, respond to their name, have joint attention, and engage in imaginative play. Language delay without an, without an attempt to compensate through non-verbal means of communication is characteristics of ASD. Fixated interest, playing exclusively with a toy, no interest in others or exploring the world is common but may only come to attention at age more than 2 or during preschool. Early intervention is beneficial includes speech therapy, behavioral therapy, educational intervention, and occupational therapy. Okay, why it is not the rate? Rate is characterized by regression of milestone with loss of previously obtained language and motor skill, including purposeful hand movements. In contrast to this patient has not yet reached expected social or language milestone. Okay, okay. These patients' psychotic symptoms rapidly improve with risperidone treatment in the hospital. However, he does not believe he does not believe he has illness, and his history of relapsing several months following discharge is suggestive of medication non-adherence. Switching to long-acting injectable antipsychotic, it is effective strategy for breaking the cycle of repetitive hospitalization. Long-acting antipsychotic are administered intramuscularly every week, every few weeks to months, eliminating the need for only eliminating the need for daily oral medication. Both first generation flufenazine, haloperidol, and the second generation risperidone, paliperidone, olanzapine, aripiprazole antipsychotics are available in long-acting injectables formulations. Patients with unstable illness who live alone and have poor social support, poor insight, and Frequent medication non-adherence are good candidates for long-acting injectable antipsychotics. These medication can be administered on outpatient basis with the support of assertive community treatment programs. Clinician can administer the drug in the patient's home or facilitate adherence to scheduled medication appointment. Next. Okay, having an imaginary friend is common in children aged 3 to 6 but can be seen throughout the school age years. Although parents may have concern when children report imaginary friends or when these relationships persist, this stage of development is considered healthy and normal. It aids it aids a child's creativity and helps the child to navigate social relationship as a form of rehearsal. There is no evidence that imaginary friends negatively impact real friendships. Other normal creative behaviors in these age group include pretend play, dress up, storytelling with fanciful details. Okay. Okay, nausea and vomiting during pregnancy affects many women in first trimester and is relatively mild with no associated weight loss. With no associated weight loss, hypovolemia, or electrolyte abnormalities. Most cases are most cases of nausea and vomiting. Most cases of nausea and vomiting during pregnancy resolve by second typically resolve by mid second trimester. Typically resolve via mid second trimester. Therefore, therefore, management is usually supportive, dietary modifications, small scheduled meals, taking medications with food at night, and vitamin B6 therapy. However, some of the cases of nausea and vomiting can mask the underlying eating disorder, as if as in this patient potential concerning finding like weight loss with an already relatively low BMI, unpredictable appetite suggesting dysregulated eating behavior with skipping meals suggesting possible caloric restriction followed by episodes of overeating, distorted view of body, distorted view of body, uh, distorted view of body weight and shape, evidenced by perception of looking pregnant despite her early gestational age, when the uterus is still below the pubic symphysis, and her switch to maternity clothes despite weight loss. Therefore, this patient requires additional evaluation for disordered eating behavior, self-induced vomiting, purging, self-induced vomiting, purging, excessive exercise in some women with eating disorder. Pregnancy is added stressor that increases disordered eating behavior. Therefore, patients are increased risk of obstetric complication, spontaneous abortion, low birth weight, microcephaly. Therefore, patients with an eating disorder during pregnancy will benefit from counseling, nutritional counseling, setting expectation for pregnancy related changes in body weight and size, psychotherapy to establish or reinforce normal eating patterns. Got it? Next. Okay, it's ADHD. The description of child's behavior is suggestive of ADHD. Symptoms of ADHD are present across two settings, home, school, and include inattentive features, forgetting chores, trouble completing tasks without repetitive prompting, and hyperactive or impulsive characteristics, unable to sit still, not thinking before reacting. In some children, unmanaged symptoms can escalate to outbursts of frustration, pushing a peer, as in this case, structural behavioral observation of symptoms obtained via teacher and parent rating scale support the diagnosis. Stimulants, methylphenidate, amphetamine are the first-line treatment of ADHD in school-aged children and adolescents due to their rapid onset of action, effectiveness, tolerability. As core ADHD symptoms improve with stimulants, impulsive outbursts, academic productivity, and parent-child interaction generally improves as well. Common adverse effects include insomnia or appetite suppression, which can be addressed by of dose, adjusting the time of dose administration, morning after breakfast. Okay, yes, okay. Having an imaginary friend, such as this patient's invisible angel, is a developmentally appropriate aspect of childhood. An imaginary friend may be human, an animal, or fantasized figure, eh, and is common in preschool and early school aged years, decreasing in frequency after age 6. It is a form of creative play that can help a child explore new ideas and overlap new ideas and develop social competence through the rehearsal of social roles in such a way. An imaginary friend can also provide comfort in patients of distress or fear, or voice to child's give voice to child's otherwise unacceptable thoughts or feelings. A child's interaction with an imaginary friend that can be quite vivid and include visual, auditory, tactile stimulation. That there is no evidence that having an imaginary friend results in social or academic dysfunction. It may in fact contribute to the development of self-esteem by increasing creative, emotional, or recreational skills. Got it? So post there is postural hypertension. Okay, they are talking about rigidity. Okay. Okay. Dementia with Lewy bodies presents with dementia plus two or more than two of the following features. Dementia with Lewy body, visual hallucination, Parkinsonism, fluctuation, cognition, REM sleep behavior disorder. Treatment for dementia of Lewy body include treatment for dementia of Lewy body include levodopa carbidopa for Parkinsonism, cholinesterase inhibitor rivastigmine for cognitive impairment, and melatonin for REM sleep behavior disorder. A trial for antipsychotic medication risperidone may be indicated in patients with functionally impairing visual hallucination and delusion, but it may be prescribed with caution due to extreme antipsychotic hypersensitivity. Extreme antipsychotic hypersensitivity in patients with dementia with Lewy body. Antipsychotic may be associated with worsening confusion, Parkinsonism, autonomic dysfunction when used in in these patients. Sudden increase in falls, confusion, orthostatic hypotension, rigidity is most likely due to recent prescription of risperidone, an antipsychotic known for stronger dopamine receptor antagonism relative to their second generation antipsychotic. When antipsychotics are indicated in the treatment of dementia of Lewy body, evidence favors low potency evidence prefers low potency second generation antipsychotic quetiapine. First generation antipsychotic haloperidol should be avoided entirely. Got it? Okay, see, okay. Mm, Although cognitive impairment, Parkinsonism, and other features may mm, worsen over the course of dementia of Lewy body, the acute nature of this patient's symptoms exacerbation in the context of recent prescription of antipsychotic medication makes risperidone a than better explanation for his prescription. Next, bipolar. Wait, before jumping into the answer, look at the creatinine. Okay, so that's the problem actually. So we cannot give lithium because lithium is nephrotoxic, and his kid and lithium causes diabetes insipidus, nephrogenic diabetes insipidus. Okay, okay. This patient's grandiose delusion, racing thoughts, distractibility, increased energy, and irritability are highly suggestive of manic episode. His history of depression at age 19. His history of depression at age 19, now manic symptoms are apparent, good functioning between episodes support a diagnosis of the bipolar 1 disorder. Bipolar disorder is highly recurrent illness following stabilization of acute symptoms. This patient will require maintenance treatment to delay or prevent recurrence. Delay or This patient will require maintenance treatment to delay or prevent recurrence of new mood episodes. Commonly used for first-line mood stabilizer for bipolar maintenance include lithium and valproate, the second generation antipsychotic quetiapine and the anticonvulsant lamotrigine have also demonstrated efficacy. These patients elevated creatinine level, diastolic hypertension, and a family history of PKD in his father suggests possible renal dysfunction, making valproate the preferred treatment over lithium. Lithium is excreted by the kidneys and to toxic level when may build up to toxic level when used in patients with renal dysfunction. Long-term use of lithium has been associated with nephrogenic diabetes. Long-term use of lithium has been associated with nephrogenic diabetes insipidus and uh, chronic tubointerstitial mm, nephropathy, which is a rare cause, can progress to end-stage renal disease. Valproate, in contrast, is not nephrogenic, although periodic monitoring of liver function tests and platelets is necessary due to medication's rare association with hepatotoxicity. Okay.
Right.
Okay. What makes you rating 2 rather than 0? Okay. In this encounter, the physician uses a numeric rating scale to explore the patient's perspective on her readiness to change and the reasons for it. The technique is referred to as evoking change talk, and in motivational interviewing, after asking the patients to assign a numeric value to her level of readiness on a scale of 0 to 5, with 5 is the highest, the physician asks an open-ended question to explore her personal motivations to change. Although this patient reports relatively low readiness, about 2, she sounds not she sounds not rated 0. She sounds not rated 0. A good starting point is to help her identify why he rates it 2. What reasons does she have right now as opposed to 0? For example, at this point, on for the patient's reasons for a 2 rating, 2 rating might include a desire to avoid another hospitalization, fear of losing her job, or concern about the effect of her drinking on a relationship. For her perspective, these reasons might outweigh the specific health risk of pancreatitis. In addition to educating the patient about pancreatitis, focusing on her internal motivations is the key to promoting change. Evoking the patient's personal reasons for change can help solidify her motivation and prepare her for planning process. Got it? Okay. Next. Okay, these patients gaps in autobiographical memory. These patients gaps in autobiographical memory and recall of everyday events and behavioral suggest of different personality states, uncharacteristically aggressive and sexual behavior, regressive behavior, and speaking in a childlike voice are consistent with dissociative identity disorder. DID is a severe chronic condition in which two or more distinct identities or personality states alternately take control of an individual. Patients also experience memory loss that is too extensive to be explained by ordinary forgetfulness. Transition from one personality to another can be sudden and is usually precipitated by stress. DID is strongly associated with a history of severe and prolonged childhood trauma, physical, sexual, emotional abuse, neglect. Personality states are often connected to traumatic experience, such as a terrified, crying child, of an angry, persecutory figure. Patients with DID commonly have chronic auditory hallucinations that have been present since childhood and are perceived as inside the patient's head as opposed to psychotic disorder in which voice. Sorry. Okay. Treatment consists of trauma focused psychotherapy. Okay, I'm reading the box now. It become monotonous. Okay. Okay. Depersonalization or derealization disorder, persistent or recurrent experiences of one or both. Depersonalization, uh, feelings of detachment from or being outside observer of oneself. And derealization, experiencing surrounding as unreal. And intact reality testing. Dissociative amnesia, inability to recall important personal information, usually of a traumatic or stressful nature, not explained by another disorder, substance use, post-traumatic stress. DID, dissociated identity disorder, marked discontinuity in identity and loss of personal agency with fragmentation into two or more than two distinct personalities associated with severe trauma or abuse. Yes. Okay. It's tardive dyskinesia. So these patients' movements are consistent with tardive dyskinesia and involuntary hyperkinetic movement disorder. And involuntary hyperkinetic movement disorder that result from prolonged exposure to dopamine receptor blocking drugs, including antipsychotic, risperidone, and metoclopramide. Management options for tardive dyskinesia include reducing antipsychotic dose, which may not be possible as it can worsen psychosis, using valbenazine and deutetrabenazine, reversible inhibitors of the VMAT2, recently approved by FDA for use in TD, and switching cross-tapering to an antipsychotic with lower tendency to cause tardive dyskinesia such as quetiapine or clozapine. In patients with a history of poor response to multiple antipsychotic, clozapine is the preferred option. In addition to tardive dyskinesia, other side effects of first and second generation antipsychotic include extrapyramidal symptom, dystonia, Parkinsonism, akathisia, which can be treated with anticholinergic. In this case, akathisia, beta blocker, and anticholinergics and beta blocker do not treat tardive dyskinesia. Next, yes. Is it catatonic exposure like first generation antipsychotic? Sorry, second generation. Tardive. I diagnosed right, but my answer is wrong. Okay. This patient's history. This patient's history of severe bipolar disorder. This patient's history of severe bipolar disorder and current immobility and mutism are suggestive of catatonia. In psychiatry, what I have figured out that when there is acute condition, you give benzos. When there is chronic condition, you give SSR. Yes, Yes. So catatonia is a syndrome, not a specific disorder of marked psychomotor disturbance that occurs in serially ill patients with mood disorder with psychotic features. Psychotic disorders, autism spectrum disorder, and medical condition, infectious, metabolic, neurologic, rheumatology. Common causes include decreased motor activity, lack of responsiveness during interview, posturing, mm, waxy flexibility. Waxy flexibility. Catatonia can range from stupor to marked agitation, catatonic excitement, which contributes to difficulty in recognition. Treatment of catatonia includes benzodiazepine, most commonly lorazepam, and is electroconvulsive therapy. A lorazepam challenge test intravenous 1 to 2 milligram, resulting in partial or temporary relief within 5 to 10 minutes, will confirm the diagnosis. Catatonia generally responds to lorazepam within a week. ECT ECT is the treatment of choice in patients who do not improve. Next. Okay, this patient's classic description of tension type headache, normal examination, and other symptoms suggestive of depression, poor sleep, loss of appetite, fatigue, anxiety, may indicate an underlying psychiatric disorder. Patients with depression and anxiety often come to the office with headache or other physical symptoms, fatigue, insomnia, non-specific aches due to lack of psychological awareness and perceived stigma around the mental health issue. In the absence of new physical findings, In a medically stable patient, the most appropriate next step is to screen the patient for depression by specifically inquiring about depressive symptoms, decreased need, decreased mood, and hedonia for patients who may be unaware of or reluctant to admit to feeling depressed. Asking if they are able to enjoy their usual activities and is helpful. Okay. Okay, we can catch tomorrow. Okay, bye bye.